So to start off the meeting, I'd like to go right into the opening session. For the opening, we have a great lineup. I have with me Dr. Teresa Kasayeva, Director of WHO's Global TB Program, Dr. Madhu Pai, who's the Chair of the PPM Working Group, and the Associate Director, McGill International TB Center. We have Dr. William Wells, who is the Vice Chair of the PPM Working Group and Senior TB Technical Advisor from USAID. We have Dr. Lal Sadasivan, who is the Vice Chair of the PPM Working Group, who's also leading health and development efforts back in Kerala and India, and also very much involved in politics, if you've seen him. And we also have in the opening session, we have Paran Sarimita Vinarni from the WHO Civil Society Task Force. This is just the opening session, but we have a great lineup of speakers across the different sessions. So let's start off, and to deliver the first welcome remarks and the opening remarks, I'd like to invite Dr. Teresa Kasayeva, who is an ardent supporter of PPM efforts and who's really been prioritizing PPM across WHO. Thank you, Teresa. I'd like to invite you to deliver the opening remarks, please.
Thank you very much, Monica. Distinguished colleagues, partners, and friends, good morning, good afternoon, good evening. Thank you for your time. Thank you for your continued fight and dedicated hard work. I know that you are both continuing providing care to people with the so-called old disease TB, and also contributing heavily into the COVID response due to your extraordinary capacity, knowledge, skills, and experience. This is indeed a very challenging time, but I'm extremely proud to be here today with you at this PPM working group, along with Dr. Madhukar Pai, our chair, two vice chairs, William and Lal, and outstanding line of speakers and panelists. So, yes, we are facing challenges. We are still in the midst of the new pandemic. But it should not be, and it never been an excuse for us to continue working for the most vulnerable, for people and suffering and dying from TB, and for their families. It's a big challenge, but it's also big learning for all of us. We should now look from the perspectives of the lessons learned from the COVID pandemic, new approaches, more digitalized approach, more engagement, and it's time indeed to engage all the care providers into the response not only to COVID but also to TB. And looking for the new opportunities and new ways of working, not continuing our business as usual. I think with this approach, we can definitely find solutions, because we don't have other chance. We are responsible for the people. We are leading together with you jointly our efforts, and there is no chance to give up. So I would like to refer to our latest releases in March when WHO presented our new approach to monthly data collection and monitoring from the countries. And we initially expected that at least 30 high TB burden countries will be able to report, but it was for us a big surprise that more than 84 countries immediately responded that they are ready on monthly and quarterly days provide data to us on TB notification. And it tells a lot. First of all, it tells that our previous investments into the strengthening national reporting systems, national surveillance system now brings results. And we know also that due to these systems, many countries are able also to report real-time data on COVID. And this clearly shows that these investments in TB in TB care, in TB facilities, in TB health workforce should be continued. And these are investments not only for TB, but also for the health system strengthening. And we can see also how massively services has been unfortunately disrupted. And this data shows the massive drop, sharp drop in TB notification. And we see now that in 2020, 1.4 million less people in compare with the previous year received access to diagnosis and treatment. And you know that the previous gap was 2.9 million plus this additional 1.4 million. It shows that almost 50% of our people affected by TB didn't receive timely access to care. And it means also personal suffering, and unfortunately death means suffering for their families. And also it means continued transmission, which is critical. And we, based on our modeling, unfortunately predict also growth in TB death, up to 500,000 additional cases of deaths attributable to TB. There is no need to remind you, you know all very well that TB remains among the biggest infectious disease killers, and especially in the lower and lower middle income countries. So we don't want to receive at the end of the COVID pandemic major outbreak of TB and so-called old new pandemic of tuberculosis. That's why the meeting like this is a critical platform to share our vision, our best practices, how we can engage more effectively different providers and to provide a response and adequately respond to the needs of people. And with this, I would like to share some the vision on the today's agenda. We are planning together to review and discuss the updated landscape analysis on private sector engagement in TB prevention and care efforts across 7 PPM priority countries, with a spotlight on the impact of the COVID pandemic on PPM progress. Findings will be shared from a rapid assessments of 15 intermediary agencies undertaken by the TB PPM Learning Network on how COVID-19 has affected their efforts and steps taken to mitigate its impact on their programs and private providers operating under the PPM schemes. So, and finally, I hope together we will identify and key solutions to accelerate, how to accelerate effectively these efforts for the engagement, to get progress back on track in countries, to reach the missing millions. I hope that our outstanding speakers, which include TB survivors, representatives of the country, civil society partners, and public and private healthcare providers will share their strong vision and experience what should be done and what should be done urgently. I would like also to remind you about 2 critical deadlines. One, of course, is ending TB by 2030. And we all understand, we critically looking at the current situation, but that it will be extremely challenging to reach these 2030 targets. But it should not be used as an excuse. We should double and triple our efforts. We should find more innovative approaches. We should be more digitalized, more patient-oriented. Another milestone will be in 2023, when we will have our second high-level meeting on TB. We have very clear targets: 40 by 22, 30 by 22. We were not on track before COVID pandemic, and now we are pushed back even further. But understanding all these issues, it's time now. It's time to brainstorm and to find solutions. And I believe and I hope that this platform will bring some new ideas and solutions. And I wish you all, and to all of us, fruitful and constructive discussions all the best and looking forward to your presentations and to the solutions. Thank you very much. Please stay healthy.
Thanks so much, Teresa, for those inspiring words. And also thank you for your commitment to PPM and constant support. It's very much appreciated. I'd now like to turn to Dr. Madhu Pai, the chair of the Working Group on Public-Private Mix for TB Prevention and Care. He is also Associate Director at McGill International TB Center. So over to you, Madhu.
Thank you, Monica, Teresa. It's good to see so many people here. I must say it's been very challenging for me to think about TB for the last month, given the devastation in India. My own family and friends have been struggling with COVID, quite desperately ill as well. But regardless, we need to think and worry about TB, which predictably will get worse. Around World TB Day, we had said as a community that we've lost 12 years of progress in TB in 12 months. And I'm terrified to ask the question, what will it look at the end of this year? Because we started the year with some optimism that vaccines will be our path out of this pandemic. And now seeing how desperate the situation is in South Asia, with India being so catastrophically hit by the new variants, I fear the worst because vaccine access is still too limited for most low and middle income countries. In other words, if you do a map of highest TB burden countries, and then you ask the question, how good is the vaccine access in those countries? The answer would be low right now. And how can the new variants not be damaging in these countries? And how can that not be catastrophic for TB? So we'll have to prepare for the worst. And as Teresa said, we'll have to double, triple, quadruple our efforts to even keep up some semblance of TB control and care going in these countries. While we do that, I would argue that every one of us needs to become an advocate for vaccine equity. Because if we do not get vaccines to all countries, we will not end this pandemic everywhere. And if the pandemic doesn't end everywhere, we will continue to see new waves, new variants, and TB care will slip and slip and further slip and slide down. In other words, getting rid of this pandemic everywhere must also be our responsibility as citizens, as advocates, as healthcare workers. We simply cannot just only talk about TB. We must demand vaccine equity. We must join WHO in calling out this vaccine apartheid that we are seeing. Rich countries holding vaccines, not supporting the IP waiver, to me is criminal in this catastrophic situation that we are facing. We must, as a community, push back and demand more from our leaders on vaccine equity, because ending this pandemic faster will be the best thing we can do for TB. Because TB is going to get hammered every single day the more we allow this pandemic to run riot. So let's do both. Let's work harder on improving TB services, but let's also become champions for vaccine equity. Any chance we get, anywhere we get, let's say what is happening to vaccines. Why is it only being scaled up in high income countries? Less than 1% of vaccines so far have gone to low income countries. How is this acceptable as new variants are just decimating populations? We must do better than this as a global health community. And COVAX is suffering, will not deliver on its targets at the rate this is going. In other words, advocating for vaccine equity, I see as a critical responsibility for all citizens, regardless of which disease area they're working or what they're working on. So with that, I'll now hand you back to Monica, with the hope that we will continue to do both the dual work of responding to TB crisis, but also making sure we get out of this COVID mess as soon as possible by championing and demanding vaccine equity. Thank you.
Thanks so much, Madhu, for those powerful words. And you're absolutely spot on that we cannot just focus on TB. We need to look at both in tandem. And thank you for raising the important issue of vaccine equity. I think that's a very good call, and our Director General has put this call out. There's a declaration that we are asking people to sign up to. We will share the link also in the chat, and we would, we echo you, Madhu. We urge everyone to join forces for vaccine equity and for equity overall, for everyone ill with COVID, with TB, whatever it is. I think we're all in this together. Um, Thank you, Madhu. So now I turn to Dr. William Wells from the U.S. Agency of International Development and Vice Chair of the PPM Working Group. Over to you, William, for your welcome remarks.
Thanks so much, Monica, and thanks to Monica and WHO and Petra and Joel also for organizing today's meeting. I think it's been such a tough year for pretty much all of us on so many different levels. And it's extraordinary to me the continued energy of this group in the face of all of those challenges. It's great to see so many familiar names popping up in the initial exercise. I do feel like this is a very kind of special technical professional community, but also just really a community of true colleagues who believe in this mission in a way, not just to address TB, but to make a much more rational, sensible health system in general. I think we need these regular reminders that we cannot tackle anything, whether it's COVID vaccines, COVID treatments, or TB treatment, with just half of the health system. If we're just trying to deal with everything only through the public sector, we have one hand tied behind our back if we're not using the private sector, working with the private sector. And I think this is also a good moment to just pause and remember that just because public-private mix is one aspect of the TB approach, it doesn't mean that it's some small, simple undertaking, and that's why we need so much energy behind this. So everything that's been done for the public sector for 20, 30 years needs to be tackled with private providers. So we need really strong intermediaries to work on PPM, but we also need really strong contracting of those intermediaries. We need interoperable data. We need social health insurance systems that actually impanel private providers. We need really great public-private dialogue in countries to navigate all of the difficulties of public-private collaboration. So we need approaches on many different fronts, and that's why it's great to see this large community, because we need all those different perspectives to come together and build an entire ecosystem of public-private collaboration. So thank you so much to everyone for joining, and I really look forward to the discussions today. Over.
Thanks so much, William. Indeed, we can't do it with one hand tied behind our back. We need all hands on deck if we are going to tackle TB or COVID or whatever we do. The private sector can't be left behind. Intermediary agencies are a big part of the story, and that's going to be part of our discussions today as well. Thanks so much for flagging all of these important points, and look forward to the continuing discussions. Over now to Dr. Lal Sadasivan, Vice Chair of the PPM, the co-Vice Chair of the PPM Working Group. As I mentioned initially, he is leading efforts in Kerala and also involved very much in the political scene recently. So over to you, Lal, welcome, and look forward to your remarks. Welcome remarks.
Thank you, Monica, Teresa, Madhu, William, and Petra, and dear PPM leaders from all over the world. I would also like to welcome you all to the special mini-meet of PPM Working Group. I'm joining from, as Monica has already told, I'm joining from India, where the impact of COVID has been severe and devastating. In the management of COVID also, I should say, we often forgot some of the basic principles of private healthcare engagement. That's what we felt here. many of the governments were initially not very responsive or proactive. And when the problem went out of their hands, some governments tried to do everything themselves instead of using the enormous resources available, especially in the private sector. So due to this, the government mechanisms often collapsed while the private sector continued to remain in the dark. Later, when private sector slowly took over, we could see governments even competing with the private sector. This means that we are seeing the same blame game in COVID too. While the governments are blamed for inaction, the private sector is blamed for compromised quality or quality of care, or for overcharging patients. And settings where a small percentage of people have health insurance or similar social protection mechanisms, catastrophic health expenditures have become the norm rather than exception. So in the process, TB programs also got heavily impacted. As a result, there is relatively less focus on TB, especially PPM. We should also learn from the neglect the TB program suffered when the focus was entirely shifted to HIV in the 80s and the aftermath of that mistake. I think it is the time for enhanced higher level advocacy for TB, especially PPM, with the decision makers in countries. And I'm not forgetting that the control of COVID also provides opportunities for fight against TB and PPM, but that's not enough. That's what I feel. The time that we have for today's meeting is very limited, and we'll continue such discussions online as a global group. And thank you all. Thank you very much, everyone, for joining this meeting. Thank you.
Thank you so much, Lal. Indeed, we need both, as we've been saying, both the government and private sector to be working closely. And that's the core of our discussions, and we hope we can influence. I'd now like to turn to Aparan Sarimita Benarni, who is a member of the WHO Civil Society Task Force on TB. She's one of our newest members. She is a TB survivor, a passionate TB advocate. She's also, one of the champions in WHO's 1+1 youth initiative. So she's one of our youth champions as well. So we're very pleased to have you join us, Paran. Paran experienced TB twice, and she started her journey in the private sector. So look to hearing from you, Paran, on your experience, but also as a member of the civil society task force. We'd also like to hear from you on what the civil society task force perspectives are, looking at public-private mix and taking this area of work forward. Over to you, Paran.
Thank you so much, Monica. Okay, first of all, I would like to thank GTV, WHO, and PPM for giving me the opportunity to speak on behalf of Civil Society Task Force at the event of Public-Private Mix Working Mini-Meet. My name, Paran Sarimita Winarni. I'm one of people affected by TB. I have 2 experience in combating TB literally. In 2008, I had what I know now as TB symptoms. I went to a private clinic. The doctor only used a chest X-ray and diagnosed me with TB. He gave me rifampicin and isoniazid and some other medicine, but I did not know what those drugs were, and the doctor didn't explain me more about the treatment. After taking those medicine for 2 years, again, only using chest X-ray, the doctor said that I was cured. Later on, I know that the treatment that I received was not according to the national nor international standard of TB treatment. This has happened even though many of my neighbors perceive that the clinic reputation is good. In early 2011, the symptoms that I had before came back. I went again to the same doctor. The doctor gave me the double dose of rifampicin and isoniazid, but my condition was getting worse. I coughed out of blood and I lost a lot of weight. My other neighbor gave me an advice to go to the primary health center, known as Puskesmas. The doctor gave me streptomycin injection. The health worker in the primary health center asked me to collect sputum and send it to a national MDR treatment referral center, which is Persahabatan Hospital at the time. Because I was a DRTB presumptive patient, after 2 months under streptomycin injection, I was diagnosed with DRTB and began my journey with the RTB medicine. It's with injection and pills. I finished my DRTB treatment after 20 months. I was struggling, trying to get back again on track after cured. I wanted to contribute to the TB response and make change, even though at the time I didn't know how to do it. Because I don't want anyone to have substandard TB treatment like me, especially in private clinic, wherein TB treatment and care are expected to be of higher standard. I was also feeling depression, stress, and I always want to die. My path to cure didn't include any services to assess my mental health issues nor offer psychosocial support. After I was cured in 2014, I was joined with PETA, the RTB patient organization in Jakarta, as the peer educator. I educate, motivate the RTB patient until now. Also realized that so many young people have highest prevalence for TB. I start the youth movement against TB in Indonesia, or IMUT, with outreach activity for raising TB awareness among young people to give education through 1+1 initiative. For my advocacy network, I joined with Global Coalition of TB Activists, TB CAP, and for the past 3 years, I became the vice chair of RGLCs in Southeast Asia as representative of people affected with TB. In the beginning of this year, I got another opportunity to actively involve as one of the members of civil society task force, building a commitment of the WHO Director General with emphasis on strengthening collaboration towards accelerating progress to end TB. Based on my experience, I felt that the capacity of the doctor in private clinic was not qualified enough in diagnosed TB based on national TB standard. The treatment also substandard. The absence of patient education, either from the medical staff or peer support. When TB services in public or hospital or primary healthcare center is free of charge, when you go to private TB services, you have to spend some money. Thus, I would like to say in this event that's really important to, on behalf of civil society task force. First, engage the private services to work together with government and people affected with TB to ensure equitable access to standardized TB treatment in all services, standardized TB information and education, TB finding case or investigation contact in the private services. Second one, strengthen health facility coordinating in managing the TB service by strengthening public and private health facility network for TB service. Both internal network, which is mean that all units, clinics, division, departments that have the potential to find or treat TB cases must follow the TB services standard. External network mean that establish the communication and coordination between the health facility so that TB patient can get access to a quality TB services. Like example, a health facility does not have gene expert machine. They must refer to the gene expert health facility. This is where the communication occurred. The specimen transport system was constructed. Not referring the patient, but referring the specimen to reduce the risk of the disease exposure. a private clinic or private practitioners find TB cases, but there is no anti-TB drugs from the national program, while patients do not afford for the medicine. So clinic or private practitioners could build a network with the government health office or cooperate with the nearest health center. The third one, there is no civil society involvement in private TB services. The role of civil society for the health office can be an advocacy partner to private services in the region. It also can be assistance and investigation contact. The fourth one, strengthen the private clinic when the primary health care, when the primary health center had on other burden with COVID, TB patient could still be served. Civil society and TB affected community play an important role in influencing and guiding private TB service networks in making sure that they cater to the needs of people with TB, who they will cater in their treatment facilities. And the last one, private health insurance apart from the social security network provided by government can play important roles by requiring TB national standard in their scheme. I noticed that adherence should belong to every level of TB services, from the government to ensure that TB drugs are always available, from the medical staff that they have to follow the TB standard of the diagnosis and treatment, up to patient to follow the doctor suggests. Adherence is not only a touch on the patient side. And I believe each of us have important roles in the journey of TB elimination by engaging all parts, community, private sectors, government, to work together in this journey. We are one step closer to end TB elimination. Thank you. Over to you, Monica.
Thank you so much, Paran, for both to you and for sharing your experience, your insights. Indeed, it's not just about, as you highlighted, it's not just about the disease itself, it's the support that's needed. You highlighted the need for psychosocial support, and this is something that we are indeed working towards. You also highlighted the need for private sector. Wherever a person accesses care, it should be of the highest quality, and that's the whole purpose of our existing as a group. So the whole purpose of public-private mix is exactly that wherever a patient accesses care, whether it's the private sector or the unengaged public sector care providers, they should get quality care, and they shouldn't have to go through what you've been through. And in Indonesia, there's been a lot of progress, and we'll have Pak Imran later, who will share in the next session with us that there's quite a lot of change. PPM has brought about a lot of change, and we hope that as we move forward, both for Indonesia and the world, that there can be more done. We've taken note of the call to action from you and the Civil Society Task Force. Thank you for those crisp 6 points. We have these noted down, and indeed we need more civil society engagement as we move ahead. So very much appreciated. Thank you, Paran. We'll now go into the next activity, which is a virtual PPM working group snapshot. I'll turn to my colleague Wong Yi, who works with us at the WHO Global Tuberculosis Program. Is part of our team, and she also leads the work on youth engagement on TB, and is also supporting public-private mix and TB elimination. So over to you, E.
Thank you so much, Monica. Good morning, good afternoon, good evening, everyone. Greeting from Beijing. I'm currently in China. My name is Wang Yi. I work with Monica and support the PPM meeting today virtually in China. It's a great opportunity to be here, and I see now we have already 112 people from all over the world to join the PPM working group meeting. That is a really great number. First of all, I would love to show the Slido. It's an interactive tool platform today that we're using for this meeting to have to receive your questions and also to interact with you through this platform. At the beginning, I remembered Monica just shared us this QR code. I would love to welcome everyone to join the Slido with us by simply just scan the QR code or join us to tap the web page slido.com and enter the password PPM 2021 0520. So now we can see we have already have 72 participants who joined us at this platform. Through here, once you joined the platform, and you could see also there is a Q&A session. We raised a question to all the participants with what do you see as quick wins and solutions to get back on track in the face of the COVID-19 pandemic? We would love to see your answers, and also if you have any questions, please put it down here so we can answer it later in our interactive Q&A session. The next part, let me show you here. We would love to invite all the panelists and also all the participants who joined the meeting today to go on with a virtual snapshot session. As you could see here, my colleague, I would invite my colleague Anna to post image link, the link of the image in our chat group now. So I invite all the participants and panelists to download the image on your computer desktop and to set it as the virtual background. If you don't know how to set it as the background, there is instructions in the chat group as well. I would love to invite all the panelists to turn on your camera, and with the image, by image background, the theme of our meeting today. So I would love to take a snapshot with all the panelists to have their camera on. I can see.
So if you can stop sharing, then we can.
Okay. Okay, I will do stop sharing. Okay, now I can see everyone is turned the camera on, and I would love to take snapshots. Thank you, and let me say 1, 2, 3, and we say cheese, and I will take a image with all of you smiling. 1, 2, 3. Thank you so much. And for all the participants, I will send you. I will put a link in the chat. We would love to have your image with our theme image, with our meeting theme as well, so we can make a giant meeting collage later at the end of the event. Thank you so much. Turn back to you, Monica.
Thank you, E. Much appreciated. So as E highlighted, well, two things. One is for the attendees, many thanks for joining. Of course, you cannot put your video on, but please do follow the instructions that E is going to put in the chat and send her your pictures. She's very good at creating a quick collage that we will try and share at the end of the meeting. And I'd like to also go back, E, if you can share the Slido question on, so what we have a Q&A on Slido, and we're using this to collect from you your quick wins and solutions that we want to collect from you throughout. So this is the Slido link, and you can see some people have already posted things, but the question is, what do you see as quick wins and solutions to get back on track in the face of the COVID-19 pandemic? You've heard some things already in the opening session, but what we want to do is we want you to continue populating this. Send us your ideas, send us your quick wins. At the end of the meeting, we have a special session chaired by Dr. Lal Sadasivan. We will go through this and we would like to do a quick ranking. So if someone has already posted a solution that you think is good, we invite you to click the upvote button. So if you click the like button, for instance, it means that the solution goes up higher. So for instance, someone has put join forces with COVID-19 activities. So E, if you can click the thumbs up for that, yeah, it goes up. So you can see it goes up. So as people post, if there is something that someone has done, upvote it or add your own. And then at the end, we can come up with a solid set of recommendations from you that we can take forward as a group. So we're running behind on time, but thank you, E. So this will be on the background and we invite you to join on Slido. If you have any other questions, please do use the Q&A chat on Zoom as well if it's linked to specific sessions. So now going straight into session 2, which is exploring the landscape on private sector engagement. So as many of you know, last year during the PPM Working Group meeting in November, we launched a special landscape analysis. This is an update from the 2018 landscape that was developed by the working group with WHO and partners. We now have the latest data available, newer case studies, and the spotlight is on the big seven PPM priority countries. These are high TB burden countries with also a large private sector. These include Bangladesh, India, Indonesia, Myanmar, Nigeria, Pakistan, and Philippines. They account for 60% of the global missing cases. As you heard from Teresa, with COVID, this has been even more impacted. In the session, we will overview the landscape on private sector engagement in 4 PPM priority countries, as well as the impact of the COVID-19 pandemic. We'd like to start first with a quick overview of the updated landscape analysis on private sector engagement. It will be led by the main author, Guy Stallworthy, who actually developed this when he was with us at WHO. He is now global lead for private provider engagement, TB, HIV, global health at the Gates Foundation. Over to you, Guy. Guy, can you hear us? Guy, can you unmute, please?
I think you're on mute.
Okay, thank you. That's working now. Let me see if I can share my screen.
Thank you.
Let me know if it's visible.
Yes, it's visible. If you could go on slideshow mode, that would be great. Thank you.
Okay. All right, thank you, Monica, for that introduction. It's my pleasure to introduce this 2020 update to the landscape analysis, as Monica said, was published in late 2018 with data through 2017. And so this is the new version. And this time there's a larger group of people heavily involved. So I want to thank the people listed as the main authors here, Monica, William and Madhu, but also Petra and Joel from the PPM Learning Network. And indeed, many, many others, too numerous to mention, from NTPs and from partner organizations in all the high burden countries who contributed to this update. What's new since the last edition? Well, I've highlighted just my sense of a few of the more important developments over the last really 2.5 years. I'm going to touch briefly on some of these in my short remarks. We made huge progress in 2018, 2019, but of course, as all the speakers have noted, TB programs suffered huge setbacks in 2020, including PPM activities. And to draw a little bit of attention to what I think is something of concern, which is perhaps a widening gap between notifications and the delivery of effective quality services, particularly in the private sector that we need to be concerned with. But more broadly, even last year during COVID, there were many positive things it's worth noting. The PPM Learning Network that I hope you're all familiar with, we didn't have that at the time we launched the first edition of this report, and you'll be hearing more about that. That network is quite extraordinary. It's got well over 1,000 active members, users across the world, and to date, I hope most of us have participated in 18 webinars on different aspects of TB PPM and indeed COVID over the last 1.5 years or so. The WHO private sector strategy may be something that is not as widely known, but I would call attention to this as what I think is an extremely positive development in the last couple of years, led by David Clark and his colleagues in the Health Systems and Governance team, and with Madhu Pai on the advisory group, spent some time consulting widely and publishing this document on engaging the private health service delivery sector in mixed health systems, which I think could be strategically a very important development to have the whole of WHO really unequivocally engaged on this issue, as William quite nicely put it, about not tackling problems like COVID and TB and health system and universal health coverage in general with one hand tied behind our backs. Global Fund, I hope we'll hear later in the meeting about exciting new developments over the last year with the new funding round and some very important new investments and increased investments in TB PPM. We'll also, I hope, be hearing from Jacob about TB Reach Wave 8, which was focused on private provider engagement with support from USAID, and 13 very exciting innovative projects funded through that round. And then finally calling out the World Bank credit in India, which is not only for TB PPM, it's entirely for TB, but it's quite heavily focused on private provider engagement. And that's in the value of 400 million and could potentially reach $500 million over the next few years. And that's, of course, an extraordinary, change and a positive development. Essentially, domestic financing, of course, because it's a credit. So those are some of the developments in the last couple of years. The document, for those who are not familiar with it, has three main sections. There's an introductory section going into some of the background and rationale and importance of private-provider engagement for TB, reviewing the evidence and the evolution of WHO guidance, and then, of course, with some updated sections this time about the TB learning the TB PPM learning network, and just touching on the issue of TB PPM during COVID-19, and about which we'll be hearing a lot more later in the meeting. Secondly, it really analyzes some of the challenging issues that we face on engaging the private healthcare sector, not just for TB, but especially for TB. And then a lot of work in this recent update to revise and bring up to date the sections on country experiences, because of course so much has changed in the last few years at the country level in these in the so-called Big Seven countries in particular. And already, of course, by next year, even this data will be out of date, and we'll have to work on updating it. But it's very exciting to see the progress in most of these countries, and of course the differences in each of the country settings. So this is just an outline of what can be found in this landscape analysis. Here I just wanted to call out one contribution from the WHO private sector strategic document that I referenced earlier. And this is just reminding us of why this is so critically important. And when we talk about the private healthcare sector, we often, some people make the mistake at least of assuming that it's more important for the wealthy than for the poorer sections of society. And this data that's in that document, I think, is quite powerful, demonstrating across the WHO regions the extent to which the private sector in dark is used by populations across the socioeconomic spectrum, differing, of course, from region to region and from country to country. But the overall picture is that, of course, as we know, the private healthcare sector is extremely important in very many settings, and not just for the wealthy. Just call out in the top left here the Afro region, where private sector is quite significantly important, almost equally across all socioeconomic groups, and it would certainly be great to see greater progress on TB PPM in that region in particular. So what has been the progress? Quite extraordinarily positive in 2018 and 2019, and it's worth perhaps remembering that as we focus on the challenges of the last year in the context of COVID. When we published the last report, we had data through 2017, and just look at that increase in private provider notifications in the Big Seven countries to more than 1.1 million in 2019. So it was really exciting times, and I think some extraordinary efforts by all the people on this call and others to achieve these results. By 2019, private sector was contributing 20%, TB notifications equal to 20% of estimated incidence in those 7 countries. So still a long way to go, but look at that wonderful progress we were making. Led by India, of course, just in terms of size, but significant progress in all the countries. The chart on the right shows the TB notifications for the private sector expressed as a percent of estimated incidence in those countries, and demonstrating, as I said, the extraordinary progress in almost all the countries. Here I'm just calling out, as I referred to earlier, that in at least a couple of countries, I think we do have to be cautious about, and ask ourselves the question at least, whether all of the notified patients from the private sector are getting the package of services that to which they have a right as citizens. Support on diagnostics, quality diagnostics, support for their treatment, the drugs, and the adherence through the complete course of treatment. And of course, in many settings, quite important social support as well. So even as we seek to recover notifications back to and beyond pre-COVID levels, I think it's important that we all make sure that those notifications are accompanied by quality service delivery. But even, and this is not in the report because it's more recent data, COVID set most programs back, and certainly we're quite familiar with serious hits to PPM as well as TB programs in general in India, in Indonesia, Philippines, Bangladesh, and Myanmar. But I think it's worth reminding ourselves that even under these circumstances, some things are possible. Pakistan and Nigeria in particular continued the increase in private provider engagement that they were on before COVID hit. In Pakistan, although public sector notifications have suffered, private sector notifications are at 16% of estimated incidents. And you can see that even during 2020, the engagement of private GPs made important gains last year. And wonderful, promising news from Nigeria after many years of stagnating performance at low levels of case finding. Thanks to the efforts of the NTP, leadership of the NTP, but also serious investments by USAID and the Global Fund. Some strong progress in private notifications and total notifications in the last couple of years. A long way to go, but very encouraging signs in that country. So I'll conclude here just to remind us all of the recommendations in the roadmap that haven't changed. The 10 recommendations that map in the landscape analysis that are the same as those in our TB PPM roadmap. I won't read them all, but I think we're all familiar with, as some of the speakers have already summarized everything that needs to be done. I was very pleased to hear Paran talk about the important contribution that civil society organizations can make to driving private provider engagement from a patient perspective. So without a doubt, we all face huge challenges of recovering TB programs in the context of COVID and tackling COVID. As everybody said, private provider engagement is even more important than before in these circumstances. But we know how to do it. And I think it's worth reminding ourselves of what was possible before COVID hit, and it was still possible in some cases during COVID, and that we can get back to this important work as soon as possible. So thank you all for your attention. Monica, I'll turn it back to you and try to figure out how I can stop sharing slides.
Thank you, Guy. That was a very comprehensive overview, and you've very nicely set the scene for the session discussions. Thank you for that. So now we have two elements in the session. One is we have a country roundtable, a country landscape roundtable with 4 of the 7 PPM, big 7 PPM priority countries. And then this will be followed by a special spotlight from the Global Fund and from Stop TB Partnership. So let me start first with the country landscape roundtable. We have 4 countries in this roundtable. We have Dr. Celine Garfin from the Philippines. We have Dr. Imran Pambudi from Indonesia. We have Dr. Raghuram Rao from India, and we have Dr. Anyaike from Nigeria. So we have a great lineup, and I'd like to start by first turning to Dr. Celine Garfam. Celine, thank you for joining us. She is the National TV Program Manager of Philippines. There's been a lot of progress. As Guy pointed out, we saw so much progress in terms of public-private mix and private sector notifications. All 4 countries, there was a big push up. Unfortunately, with COVID-19, this situation has changed drastically, as shared before. Celine, so over to you. Good to hear from you. If it would be great if you could share with us what's happening, what's the landscape in terms of private sector engagement in the Philippines, especially in the current context of COVID-19.
Thank you, Monica, and good morning, good afternoon, and good evening, everyone. So I'll be sharing my slide. So this is our, can you see my slide?
Yes, we can see your slide.
Okay. So this is our experience in the country. So first, this is the trend of the contribution of the private sector from 2015 to 2019. So I'll give the details of the 2020 in my next slide. So if you can see, the trend in the contribution of the private sector has really increased for the past years. And in 2018, this is the year that we introduced the mandatory notification. And if you notice the increase in the contribution of the private sector from 40% to 56%. So we're really getting strong in the engagement of the private sector. But in 2020, we have a decrease in the TB notification, both from the public sector and the private sector. So this is the trends that we have. So initially in Q1, we have a good accomplishment, and we are expecting that the cases would really be increasing already, since we already put in place the different infrastructure for us to provide the TB services. But with COVID-19, that is actually that's in March, we have our community dissemination of COVID-19. So if you can see, there's a decrease in the number of cases from Q2, Q3, and Q4. And if we look at our data for this year, initially, there's already an increase in March of this year, but last April, there was a surge again in the COVID-19 cases, and the number of cases that we have notified has also decreased. Okay, so these are the challenges that we have with the COVID-19 pandemic. So we have reduced face-to-face consultation, and in fact, some of the hospitals and even the private clinics closed because of the fear. And initially, we have very limited stocks of PPEs. Then we also have limited access to gene expert testing and medications. And to address this, we have our striders, our sputum transport riders. So initially, they transport the specimens, and this would only include the public facilities. But later, last year in 2020, we already included the private sector. Then we also have limited facilities for TB, because especially in the hospitals, since most of these hospitals became COVID referral facility and vaccination sites. So there were limited services. Then one of the key challenge really is the human resource. So TB physicians and nurses were assigned to other units as a response to the COVID-19 pandemic. And then some of the hospital staff were quarantined, since some were infected and some were exposed to COVID-19. And then there was reduced or no contact investigation due to the HR issues. And even the community, or the people, a fear of going to the hospital for screening. But despite these challenges, we still have our PPM activities. So one of the activities that we're having now is with the Universal Health Care Act. We are engaging the private physicians and private facilities as part of the healthcare provider network in a province or highly urbanized city. So the USAID project is helping us to come up with this model. And with the latest development in our office, wherein we have to integrate our services. So we're doing not only provision of services for TB, but for HIV as well, since TB and HIV integration is one of the flagship strategy of the Department of Health now. Then we also have the implementation of the mandatory notification nationwide. And just before the lockdown in March last year, we were able to launch our IT slide, that is our information system, to help the private physicians to report their cases. So this application is very user-friendly, since we are only asking for very few variables. Then we also have our Philippine Private Sector Diagnostic Consortium. So this is a group of hospitals and private diagnostic centers that group together so that they can provide less expensive gene expert testing. And this initiative is supported by the TB Innovations Project of USAID. Then we also have TB in the workplace. We still continue our hospital engagement, and we have support from the Global Fund for this. Then for the country, we have ongoing PPM assessment, as well as coming up with models on how we can sustain the engagement of the private sector. So hopefully, once we have the reports, we will check on our strategies. So we might revise or enhance some of our strategies. And I would also like to add that for the COVID-19 vaccination, TB cases are included in the A3 priority list. So that is people with comorbidity, and they have included TB as one of the comorbidity. So that's all for the Philippines. Thank you.
Thank you so much, Celine, for that comprehensive overview. Indeed, it's taken quite a hit, but yes, picking up. So thank you for sharing what's happening right now in the Philippines. I'd now like to turn to Pak Imran, NTP Manager from Indonesia. Hello, Pak Imran. It would be really good to hear from you on the private sector landscape right now in the country, especially with COVID-19 impact, and what actions have you been taking in this time? Over to you, Pak Imran.
Yeah, thank you, Monica. So good evening, everybody from Indonesia. So let me share my screen. Okay. Yeah, so Indonesia, like every country in the world, has impacted to the COVID. So in Indonesia, since March 2020, COVID entered to Indonesia. And it is the progress of the COVID response in Indonesia. So yesterday, we have more than 87,000 active case COVID. So if we look from this numbers. So we can see here that in one day, we have additional more than 4,800 new cases every day. And this is also, I want to share about the progress of vaccination, COVID vaccination in Indonesia. So in the first phase, our target is around 40 million from more than 140 million total target in 2021. So it means that this also burden for public health facility. It means that if you're talking about the PPM, private, what we call private clinics. So this is the opportunity for the private clinics or private providers to have more role in the TB services, because the public service is very busy to the COVID-19 and also the vaccination campaign. So this is the impact of COVID-19 in Indonesia. So we have 4 impacts. One is the declining of TB notification is declined by 42%. We also have a deteriorating treatment outcome by 1%, diverted resources related by TB facility, funding, and human resources. So like also mentioned by Celine in Philippines, so in Indonesia also many hospitals, TB hospitals converted to the COVID referral. So we should rearrange the TB service in Indonesia. So the declining of TB notification by 42%, it's because of the most probable cause is the reporting delays at health facility. And this also make a proof that if we only rely on the public services, it will be not sufficient. And in 2020, unfortunately, Indonesia has also transition process to the system information from the old one to the new one. So we hope in the transition will be okay, but since COVID pandemic make us cannot make like socialization and workshop, so it also have impact to the transition. It's not smooth. And the other cause is about the community-based TB contact investigation. So the cadres or the community, they don't have courage to go to the community to help find new TB cases, because they're afraid also to be infected by COVID. NTP already make the protocols how we deal with the COVID pandemic situation. So we already declared the protocol since in the end of March 2020. The protocol, one of the point is we want to make like longer to the to make TB patient not too frequent to visit the health facility, because we don't want the patient have a risk to get the infection of the COVID. So this is the TB case notification 2019 to 2020. So we can see here that both of the public and also private is a decrease if we look from 2019 to 2020. Yeah. All is the decrease. Even though if we look for the number of the health facility that report of the patient, we can see here that in 2020, it is slightly increased from 941 hospitals, private hospitals, to 955 private hospitals. But if you're looking for the private clinics, it's dropped nearly half from 263 to 178. So I think the increase of the numbers of private hospitals that reported TB cases is also one of the what we call the effect of several efforts that we made by NTP and also by the project by USAID TBPS. So if you look this graph, yeah, this is the graph from January to December. So we can see here that both of private and also hospital and also clinics, they like to what they call wait until the December. So like we look in this graph. So in 2019, in December, the case notification in December 2019 is rising up. Yeah, and also the private clinics. Yeah, because usually in the November and December, the NTP and also the district health office make like intensified case finding or mopping up. We visit the hospitals and also the clinics to find out maybe they have more what we call report a TB patient in their health facility. Ladies and gentlemen, so in the early 2021, we make like catch-up plan. Yeah, how we can catch up the TB program in 2021. So we have 4 big strategies. The first is to manage to catch up and achieve intended target. Second is ensuring safety for the healthcare workers, because if we cannot guarantee the safety of the healthcare workers, they are not willing to give the best serve to the patient. And the third is how we can ensure patient comfortable for the service. And the last is how we can protect TB patient. So these 4 strategies, we explain to the several activities for the public and also private health services. In 2020, we have a strategy how we can deal to the public-private mix. So I don't want to read all of the strategies, but I want to highlight some strategies like the strategy number 2, how to improve the quality of TB service. So like Paran mentioned, yeah, from her past experience, the quality of the TB services in the private clinics is not matched with the standard. So that's why we develop concept of TB coach and the TB champion. So in this idea of the TB coach, we selected member of professional organizations to provide assistance and mentoring to the clinics. And also in the improve of the quality of TB services, we also, into 2021, we make an initial engagement of the big chain hospitals. And the other strategy that I want to highlight is the third strategy of the strengthen of the roles of multi-program. So nowadays we improve the role of professional organization like private hospital association, district and province hospital associations, and all Indonesian hospital associations in terms of TB services and the network. So we also encourage professional organization to establish the coalition of the private clinics with a clear work plan and the task. How we can make a recovery plan with the private? So with the support of Global Fund and also USAID, the private sectors, we make intervention in 80 district PPM, priority district, which is estimated to cover 45% of the TB burden in Indonesia, as well as 41% of public clinics, 68 of private clinics, and also 54% of hospital in Indonesia. So it means that even though it's only 80 district of 315 district in Indonesia, but the coverage is quite huge. Several activities we have already done, like the technical assistance for resetting layout and adjusting service flows at health facilities, reducing distance of access, enable provision and systemic data validations. And we also make or develop the call center to assist TB information system data entry and support connectivity between TB information system and hospital information system. And we also, like I mentioned to you before, that we engage with the 5 top big chain hospitals in the country by providing human resources support to conduct intensified TB case finding in 130 private hospitals in 68 districts and 26 provinces. And the last, we also developed the awareness campaign, especially with the digital technology. So I think Williams also mentioned one of the recommendation for the PPM is how we can intensify digital technology. I think that's all from me, Monica.
Thank you so much, Pak Ibran. I think that was an excellent presentation. You showed us clearly the data, which showed, what the changes have been and the significant impact. And thank you for sharing that last slide, especially on the recovery plan. I think that's really something that we need to replicate across all of our countries. Thank you so much. Now I turn to Dr. Raghuram Rao, Joint Director TB from the Ministry of Health and Family Welfare from India. Dr. Rao, over to you, please, on the landscape. We know India is really struggling with COVID right now. And in the face of this, what can we do to strengthen PPM, make sure all hands are on deck to tackle both TB and COVID? Over to you, Dr. Rao.
Yeah, thanks, Monica, and thanks, everybody. Good morning, good afternoon, good evening to all participants across the globe. While this presentation is being shared, I just wanted to update that in spite of the intense second wave and quite impactful first wave, we still were able to focus on TB activities and keep it on priority within the ministry, so that the mitigation measures that we deploy are continued and we have minimal impact on TB services as far as possible. Monica, is the presentation being shared from your side?
Yes, it is. It is.
Yeah,
it is.
yes.
Thanks,
Second
Anna.
wave and quite impactful first wave, we still were able to focus on TB activities and keep it on priority within the ministry, so that the mitigation measures that we deploy are continued and we have minimal impact on TB services as far as possible. Monica, is the presentation being shared from your side?
Yes, it is. It is.
Yeah,
it is.
yes.
Thanks,
Second
Anna.
wave and quite impactful first wave, we still were able to focus
I think,
on TB activities,
Monica,
and it's
Yeah,
getting
something's going wrong.
yeah. It's on auto mode.
Okay. Yeah, I was wondering why you're.
Speaking twice, huh? Yeah, I think
Yes.
it's probably resolved now. So yeah, thanks. So yeah, next slide. So I'll just be speaking a few slides in terms of where we are on the landscape part. We have a huge private sector presence across the country, and the length and breadth of the country, we have almost 3/4 of our population seeking care, from the private sector at the primary level, as a first entry, and it's almost equitably distributed in rural or urban, little more on the urban side, considering the density of population and the availability of private sector. So this is based on a lot of surveys that happen throughout the year across different sectors. So NSSO data says that 67.5% rural and 73.8% in the urban population seek care in the private sector first. So that's the entry point, and that almost equally applies for TB. And we did last year we did a huge exercise of mapping of private practitioners and infrastructure available in the entire country. We did that, except West Bengal could not be done, but otherwise across the country we could map 4.8 lakh health facilities, of which 1.5 lakh were providing TB services, and around 60,000 of them were private health facilities. Now this survey happened across public and private sectors, trying to put on one cross section all the healthcare facilities, identifying, including geolocation. So this was an exercise done. But at the same time, in Nikshay, which is our case-based reporting software, in that we have almost over the years, of course, this has been built up. So a lot of facilities have been registered. Over 2 lakh facilities are registered. In that we have over almost 170,000 hubs or hospitals registered, and then laboratories around 21,000, chemists around 51,000. These are the ones which are registered, and we have notifications from these number of health facilities across the country. And also in we have an upcoming strong insurance sector. And in the private, of course, there is a huge ambitious government initiative of insurance called the Pradhan Mantri Jan Arogya Yojana, and in that we have public and private hospitals empaneled in there, where insurance for over 500 million beneficiaries is being provided for at least 5 lakh, 500,000 coverage for IPD or any admissions or any procedures required for them. In that also TB services are included both for adult and pediatric population. Also another survey where we saw was that only 3% of the rural and 9% of the urban populations avail some insurance schemes, government sponsored schemes. This of course happened at different time points, and then the PMJAY kicked off, and this is expanding very rapidly, and we are trying to literally get universal coverage with this initiative. Next slide. So in terms of what we have done in the private sector over the years, almost a decade and a half, has been spent in terms of building the relationship in the private sector and scaling up different interventions with pilot projects. And now a lot of it is now domestically funded, and a huge, almost 80% of the funding for TB program, is primarily from domestic budget sources. And in terms of enabling private sector notification, of course, we made it mandatory. And, for notifying TB cases by any laboratory, chemist, pharmacist, if he comes across a TB case, he has to notify that. And also making sure that contact details of the patient is taken care. And in case they don't do that or not notify case, there is also penal provisions available. And some of the states, districts at the local level have actually enforced the penal provisions also. Parallelly, we over the last 5 years strengthened the monitoring of sales in the private sector, of drug sales in the private sector, and anti-TB drugs being Schedule H1 drug under the Drugs and Cosmetics Act is something which cannot be prescribed ideally over the counter. And so the monitoring of that has been enforced, so that we are able to track the prescription based on which the sales has happened, and also the contact details of the patient, so that we get back to them, get the case notified, and provide public health actions to them. Also under the program, we have made provisions for incentives and enablers, with incentives for notification by a private practitioner, 1,000 rupees, 500 a notification, 500 an outcome, or just anybody in the community who can identify a suspect, refer it, and if it turns out to be TB, he gets an incentive, he or she gets an incentive of 500 rupees. Or also for somebody who takes the responsibility of ensuring providing treatment support and ensuring the patient completes treatment, incentives of 1,000 rupees for drug sensitive TB and 5,000 rupees for drug resistant TB is available. And this irrespective of the sector, be it public sector or private sector, so these provisions are extended to somebody seeking care in the private sector, and somebody taking responsibility of his treatment. These incentives are also given. Also to boost the health infrastructure and engage with the private sectors and utilize the huge infrastructure and skills available in the private sector, partnership schemes have been designed, and it's recently released just before COVID in 2019. And this guidance document is moving away from the traditional input-based contracting and goes towards output-based contracting, pay for performance models, and not prescribing rates, but encouraging states and districts to insource services from the private sector if there is a gap in the public sector, and at local rates, whatever is the market prevailing rates based on competitive bidding. So these guidances have also helped the states and districts in the health system to insource a lot of services apart from drugs or diagnostics or whatever, in terms of any gaps in making sure that we provide standard care to the TB patients, irrespective of the sector, public or private. We have utilized partnerships schemes like these to use interface agencies. The example of it was piloted first in 3 cities in Patna, Mehsana, and in Mumbai. And then those models, of course, with Global Fund support, was scaled up. The initial pilots were done through support of BMGF, where demonstration models projects were done, and then we scaled it up with Global Fund grants to cover 103 districts, primarily high burden and high intensive private practitioner presence districts in 2021, and then scaled up almost 3 times in using domestic resources in now. And currently we have almost we have around 700 odd districts, so almost half of the districts are covered with an interface agency model of bridging or acting as a bridge between the public sector and private sector to increase this access, and to support these interventions, monitor these, and help the state district in contracting and have these output based contracts with NGOs or agencies. We have established 1 national technical support unit and 9 state technical support units in priority states. These are World Bank supported project. So in these states, we almost cover almost 70% of our total burden, and including the private sector burden. So major chunk of the country gets covered by focusing on these 9 states. Next slide, please. So by doing all these things, what was the impact? We were doing well 2017 onwards, and almost notified 2.4 million cases against an estimate of 2.6 million. And however, COVID came in 2020. We almost had a 25% fall, and currently we are going through a second wave and a larger one. And with that, we have currently seen almost in the month of April 40% down notification. But knowing the capacity of the health systems and learning from the experiences of last year, the SOPs are in place. The states, districts know what needs to be done immediately after the wave settles down to revive back and kick up the TB program. So we hope to reach somewhere close to 2 million cases this year, in spite of all the challenges with the COVID that we are facing currently. And in terms of private sector, if you see, in 2017, we were getting around 21% contribution in the overall case notifications. That has increased, and in spite of COVID, that proportion continues to increase. And in 2020, it was 30%, and now 32% so far in the current year. In the 4 months that we are able to see. So a huge contribution from the private sector, and we hope that continues. And it's not just at notification. If you see, almost in terms of the molecular tests done in the labs that we have from the private sector samples, or cases referred from the private sector. In 2017, that was somewhere around 93,000, and now we are testing over 200,000 cases or samples from the private sector alone. Also, the interface agencies and the extra efforts that we are putting in through these mechanisms is trying to provide quality services for TB patients in the private sector. And we are able to increase microbiological confirmation now amongst the notifications from the private sector to over 30%. UDST, although it was quite low, we have increased that to now 11% and focusing to make that at par with the public sector, where we are somewhere close to 60-70% coverage. And then HIV almost 80%, now 85%. Treatment success also among the patients notified in the private sector, we were able to get around 81% in 2019. And all these in 2019 being a World Bank project, supported project. This was also verified by an independent verification agency, and so strong quality data is being now pursued, and especially because of the interface agencies and the support of these models, we are able to ensure quality services and increase access to free drugs and diagnostics for patients seeking care in the private sector. Next slide, please. And coming back to COVID, of course, in 2020 and in 2021 now, for the first 4 months, we have seen during lockdowns at various stages. Last year, we had a national lockdown, and now this year we are having localized lockdowns. And in these, there is closure of health facilities. That private sector also is impacted by that. Transportation access for people to seek healthcare gets limited. Human resource from the program and infrastructure, including the molecular labs, were diverted to a large extent in 2020, and in 2021 now it's limited because we have roped in additional human resource for, especially for for COVID activities. And also we have scaled up our laboratory infrastructure almost 3 times, molecular diagnostics including, and we have over 3,100 molecular machines across the country, and it's reached now below district level. So we are targeting by 2021-22 to reach almost 5,000 odd molecular diagnostics, and transition away from sputum microscopy as the primary tool for TB diagnosis. Also, we use this opportunity for COVID to strengthen our systems and invest more in molecular diagnostics, in strengthening the IPD facilities to have isolation centers and airborne infection compliant settings at almost every district now. So that is definitely going to be useful for tuberculosis going forward. COVID also had this dual impact of stigma, which we saw, where people, because of fear of getting isolated or quarantined, restricted themselves from seeking care and started hiding, and there was increased stigma that we saw. And also this overlap with the TB stigma already. So any cough was taken as as a suspect for COVID, and people were stigmatized. So at the community level, at individual level. So we came up with targeted communication campaigns to focus on these, and also specific campaigns, communication campaigns to focus on sustaining the COVID appropriate behaviors of wearing mask, personal hygiene, hand hygiene, not spitting in public places, cough etiquettes, mask, all those things, to sustain that, because that will definitely have an impact in community transmission for all airborne infection, infectious diseases, and including TB. So this was overall, the impact, and we of course went on a mission mode in terms of mitigating the impact. Huge, digital interventions for monitoring states, districts through electronic, reviews, and using that for capacity building also, and using digital technologies for monitoring patient adherence. Came up with innovative models for home-based collection and drug delivery, so that for the cases diagnosed, notified, on treatment, the services are uninterrupted. Engaging with professional associations was very critical to revive the private sector back, after the lockdown phases. So that's something, very targeted activities we did at all levels and across all associations, not just the chest association or the laboratory networks, but across different specialities. We motivated them to get back to opening their clinics, hospitals, laboratories, and start providing services to to the patient seeking care. Also, telemedicine and tele consultations were used extensively for for overall healthcare, but also we made sure that TB is not missed out, and anybody who has cough or any sign symptoms which were persistent or suspecting of tuberculosis were used, where telemedicine was used for providing guidance at the home, and if required, sample collection at home and confirmation of diagnosis and providing drugs at home. So these were innovative models that helped us scale up, and we did not restrict that to public sector, but extended that to the private sector also. we had a very strong call center which was doing TB work. This also got repurposed for COVID to a large extent during last year, but we then enhanced the capacity of the call center, increased additional seats, call center agents to provide COVID services separately, and got back the consultants or the call center agents for providing TB services. And this was used also to provide a lot of outreach, outbound calls to reach out to patients to make sure follow-ups are done, and any issues, be it for drug refills or for a lot of social benefits to increase access to that, the call centers were used extensively. Next slide. So that's in short what I wanted to share in terms of what we have done in India to sustain the TB response, not relax on the TB front, and keep up with the private sector especially. Thank you.
Thank you so much, Dr. Rao, for a very comprehensive overview. So there's scope for optimism despite all of the challenges. So wish you all the best. So moving on now, thank you, Dr. Rao. Moving now on to Dr. Anyaike from Nigeria. We are indeed running behind on time. Apologies for that. And with your permission, we'll try and extend till 4. But for now, we'd like to turn to Dr. Anyaike to hear from Nigeria on the private sector landscape, impact of COVID, and mitigation steps. Over to you, Dr. Anyaike, who is the new National TB Program Director, National Coordinator in the National TB Control Program in the Federal Ministry of Health, Nigeria. Dr. Anyaike, can you hear us? We can see your screen, but we cannot hear you.
Okay, can you hear me?
Now we can hear you, indeed.
Yes.
Would you like us to share the slides? Will that be more helpful?
Yes, that will be very fine.
Okay, so if you could stop sharing, we will share slides from here.
Okay.
Please proceed. Please go ahead.
Okay, so just a background for Nigeria. At least you have the data that Nigeria contributes significantly to the burden of tuberculosis, both in Africa and in the world. And then we have an estimated of 440,000 cases in a year, but all our efforts were able to detect 30% with 70 of the cases missing. And then we also have the data to show that 60% of the Nigerians seek their healthcare services at the private sector. And so in our bid to scale up our TB intervention, even with the TB strategy, we gone down on component 4, which is to engage all health facilities, both private and public, in the provision of services. So in 2019, we had the support from Global Fund and from the USAID. Next slide, please. And yes, and then so we were able to document that with proper engagement of the private sector, that we'll be able to improve on our case certification. And the strategies we use were enrolling all the private practitioners, both faith-based and private for-profit. And then we also engaged private standalone laboratory for expert testing, which turned out to be the highest testing in the country. And then the use of mobile apps for easy screening of reporting cases. On the right side of you will see the trend of engagement. We try to look at what happened in 2017 and 2020. You will notice that the faith-based organizations, notification increased significantly. And then with private for profits down to referral entities, all showed marked improvement on case notification. And now in 2020, I came up with the COVID-19 pandemic. The first quarter came out with a lot of, hiccups with the lockdown, and then with the stigma and discrimination, people were not going to the public hospitals, and so we now had to put in a strategy. Of course, you know that the healthcare in the country is being operated at 3 levels. So at national level, we sent a letter of support to essentials to cover the essential staff even as they go out for their activities. This is to allow them to move even during the lockdown. And then we had to work on building the capacity using the virtual platform of the private healthcare providers and ensure that we don't have stock out of medicine and other commodities. So we supported the private health facilities with PPE, and then the facilities were supported to institute the infection prevention and control measures. Then virtual platforms were used for capacity building, patients being triaged, when they come because of the fear of the COVID-19. And then virtual mentoring and supervision for private healthcare providers. And then at the patient level, we use the community structures to monitor case holding and also for active case detection. Next slide. Now, in continuation of TV services during the lockdown led to increased PPM contribution of 23% in Q2 and also 26% in the annual case detection. I think we could also see that within that time, because of the stigma and the discrimination and the lockdown and people getting apprehensive of going to the public hospitals, that opened the shift to the private sector. So when we looked at the trend, in PPM contribution, it got to 23%, and the Q2 in 2020 and 26% at the annual case detection. Now, when we look at the case detection, case fund increased by 15%, and PPM cases had improved 108 compared to the previous years. So if you look at the data closely, you will see that in 2020, ended of 2019, we had a total of 120,266 cases. But at the end of 2020, we had 38,591, showing an increase of 15% despite the COVID-19. Then on the PPM, you will see that in the year 2019, we had 17,250 cases, but at the end, we were able to achieve 35,865 cases, showing, an up jump of 108% increase. So it's already documented that what we have to do, because 60% of the Nigerian population seek care at the private health facilities. So our next step is to work closely to ensure, work towards having 100% engagement of the private facilities and engage more private standalone labs for expert testing. Of course, we need to put other mechanisms of ensuring primary prevention and others in our strategic moves towards ending tuberculosis in Nigeria. Thank you.
Thank you so much, Dr. Anyeke. A great presentation, very succinct, to the point, and welcome to the PPM Working Group. You are very new in this role, and we really look forward to continuing our collaboration, and we will continue to reach out to you. Thank you so much for joining us.
Thank you. Thank you.
I'd now like to turn to the next part of the session, where we have a special spotlight. We have two presentations here. One from Dr. Mohammad Yassin, Senior TB Advisor from the Global Fund, and the other from Jacob Cresswell, Head Innovations and Grants at Stop TB Partnership. So let me start with inviting Mohammad, who will present on transforming the PPM landscape through the Global Fund Catalytic Fund Strategic Initiative and the CR19 RM to reach the missing millions. As we all know well, this has been one of the big pushes that we've seen, the spike in notifications. So over to you, Mohammad. Thank you so much.
Thank you very much, Monica. Good morning, good afternoon, good evening, everyone. Thanks for inviting us. Maybe can you have my slides, or I can share my screen as well.
Yes, we're sharing, Mohammad. Give us a minute.
I think I can share. I hope you can see my slides.
Yes, we can see your slides. Please proceed.
Yeah, okay. So, yeah, thank you very much again. So I will be highlighting the opportunities from Global Funds to support PPM activities. And I just want also to share with you an update opportunities from the Global Fund, including the part of the catalytic funding, the strategic initiative, and the COVID-19 response mechanism to support countries. Just a quick reminder that the Global Fund overall contribution to PPM activities in those 7 big countries, which account for 50% of Global Fund TB portfolios. You can see the big jump from 3%, which was like before the new funding model, that increased to 5% in NFM1 and to 14% in NFM2. And we are compiling the data for the next 3 years, as most of the countries have already submitted the funding, and the trend has been increasing, and this is including use of reimbursement efficiencies from the funding, which supports PPM activities, and also allocating more budget for PPM activities as part of the momentum in finding the missing cases. Most of the grants also prioritizing PPM. As already highlighted, most of people who especially in Asia and including in Nigeria, accessing TV service in private sectors, and that's where we are missing many of them. So that's an opportunity. But Global Fund, on top of the allocation to countries, also provided a catalytic funding for TB. That catalytic funding is addressing the missing millions, and as part of that, countries receive additional money, call it matching funding. But we also work with the WHO and Stop TB as part of strategic initiative to support countries to implement what they plan to find those missing millions. As part of this, new principal recipient were created, including in Nigeria. Probably it's a big jump, maybe related to creation of a new PR and more resources available for private sector, and that's what we have seen. And several countries have been assessing the effectiveness for the different models and recommending and incorporating more innovative approach. Further opportunities are also available as part of the overall UN high-level declaration to reach 40 million people, and as part of mitigating the impact of COVID on TB, and there is obviously understanding on increasing the engagement of private sector and scaling up innovative interventions, which are already highlighted by previous speakers from countries, and co-financing and catalyzing new initiatives to contribute to private sector engagement. And Global Fund also has created new strategic initiatives on private sector engagement, including looking at different contracting approach and engaging interface intermediaries, learning from India, Pakistan, and other countries which have already been implementing this approach. That's ongoing, and we believe this will contribute to overall improving the support for PPM activities. Just a few highlights for TB catalytic funding, where we had this catalytic funding for 13 countries during the previous cycle, but going forward, the coverage and the scope expanded. Now we have 20 countries which account for 82% of the people, missing people with TB, and these countries receive 150 million additional funding. But as part of this catalytic funding, 14 million available for strategic initiative where country demand-based driven technical supports are provided. Overall, the focus is in finding the missing people with TB, including drug-resistant TB and TB prevention. The strategic initiative which you have with WHO and Stop TB has two components: the global level, where we work with Stop TB and WHO, but there is a component which you call it a country level support, where each of those countries would have about 100,000 per year for technical supports, which are based on the country needs. And here is just to highlight some of the thematic areas which countries indicated that they would like to have support. And the PPM is one of the main parts highlighted by most countries. And you can see COVID mitigation and the recovery plan is also part of that. As part of the PPM, you can see that there are several items which are already highlighted by countries, which they would like to have technical support as a demand-based support, which is requested by countries, and we are working with partners and consultants to support countries depending on their need. The other issue is overall COVID, and already highlighted. I don't really need to tell you this again, but it's a concern for Global Fund as well on overall disruption on TB, including reduction on notification. You can see that, as Pak Imran also mentioned, in Indonesia, 42% reduction, and it's ranked to Pakistan, where the reduction in TB notification on 17%. Also in Pakistan, as I mentioned, the private sector support notification may not have declined, but overall there is a 17% decline in TB notification. And then India, you can see 15%. And overall, 1 million fewer people were notified in these countries, and high impact Asia countries, all the countries represented here, are most affected, including South Africa, where the COVID impact really affecting TB notification. And as already highlighted, the situation in India, where there is already a recovery, but now with the current situation, this may have impact on the future notification, not only in India, but in neighboring countries as well. And Global Fund has also been monitoring the performance of indicators, and you can see that the TV notification, those selected countries where we have been monitoring indicators, declined by 25%, 27%, and MDR TV 39%. And again, the high impact Asia countries affected compared to others. And overall, TB is disproportionately affected, and we are talking about TB, HIV, and malaria within Global Fund. But it's not also surprising because the two COVID and TB affect the respiratory tract and similar symptoms, double stigma, and most of the resources, Dr. Celine also mentioned, that the first one to be diverted to COVID, that the TB resource, human resource, and facilities, that's contributed to overall reduction in TB notification. Global Fund, as you may know, has received generous support from US $3.5 billion for COVID response, and 140 million euro from Germany as well. And the Global Fund already allocated this funding to support three areas. One is for COVID control and containment. The second part is COVID-related risk mitigation on TB, HIV, and malaria. And the third part is for health and community system component. And countries are now submitting their funding requests. There are two modalities. We call it the fast track, which are more for commodities, for COVID-related commodities, and the full funding requests. So far, over 20 countries have already submitted, and the 5 countries already received funding as this was approved. At the priority interventions, I think I just want to highlight from Global Fund side, we do have the information which is available in our website, and we are promoting the scale up of innovative interventions as business as usual may not work in the context of COVID. Dual interventions for both TB and COVID should be promoted, and including, TB diagnosis, treatment, and prevention, including as part of the COVID response as well. But obviously, it requires to adopt TB programming in the context of COVID, a more decentralized, community-based approach, and reducing the stigma or double stigma. And we already learned a lot from COVID, and we need to really accelerate the move to real-time case-based reporting, digital technologies, and so that this will inform our decision. And as you can see, the private sector engagement needs strengthening, including contracting, scaling up, innovative intervention, and increased diagnosis, notification, treatment, and prevention as well. This is my last slide. It is more on the funding opportunities. And for most of the innovative and priority interventions, countries could use existing grant and flexibilities available, including saving efficiencies and reprogramming of the existing grant and portfolio optimization. This is ongoing. It's not just this month and next month. Countries, partners, and national TV programs should explore opportunities for this support and work together with our country teams as well. And COVID interventions, which are cross-cutting, help TB as well. As you all know, that infection prevention and control, or the PPE, the lab component, or the PCR, gene experts, sample transportation and contact tracing, the surveillance, health and community systems are part of the COVID pillars, could be supported as part of the main or the pure COVID component, but this will also contribute to TB. And if there is inadequate funding within the grant, countries could use the C19 RM, that's the COVID-19 response mechanism funding to support operational costs to mitigate the impact of COVID on TB. That's what I would like to share with you, and I would encourage everyone to be engaged during this funding request development implementation as opportunities are available within the Global Fund. Over.
Thank you so much, Mohammed. Lots of great opportunities and support for the Global Fund, especially to mitigate the impact of COVID on TB and opportunities for greater private sector engagement. So thank you so much for that overview. I'd now like to turn to Dr. Jacob Cresswell, Head Innovations and Grants at the Stop TB Partnership, to share with us how you are scaling up innovative approaches to engage the private sector through TB Reach. Over to you, Jacob.
Hi, everybody. Thanks, Monica. And I know we're short of time. I won't be long. I just have 3 main slides. As Monica mentioned, my name is Jacob Cresswell. I lead the TB Reach initiative at Stop TB. For those of you who may be unfamiliar with TB Reach, it is an initiative of the partnership that is primarily focused on testing and implementing new ways of improving case detection and notification. So that while there's been a lot of focus on diagnostic testing, active case finding over the last years, and TB Reach has certainly been at the forefront of supporting these efforts, we know that there's a huge proportion of people who are missed by the national TB programs that are seeking care in the private sector. And it's been well described on this call and others. So, and just to say that TB Reach is fully committed to supporting these types of approaches as well. In fact, almost 70 grants, 67 grants that we've counted have looked at supporting private sector engagement through the first 8 funding waves that we've supported. And our wave 8, which was last year, was only a call that was exclusively on private sector. So as is in comparison to the work that Mohammed is leading and Global Fund, these TB Reach grants are small in size. They're the maximum amount of $1 million, but they are very short duration, 12 to 18 months. So that amplifies the impact that they can have, and they're very focused on service delivery. So, to date, in the projects, we've documented more than 60,000 people with TB linked to treatment and notification through these private sector engagement grants. If you go to the next slide, please. So as has been discussed and you've heard and continue to hear, PPM is not a one-size-fits-all approach. There are, as Guy and others have mentioned, really nice publications and guidelines on PPM, but guidelines can't be standardized in the same way that you can for maybe diagnostic tools or treatment or something like this. And it means that really we need different models that are adapted for different settings. And again, you've heard a lot already about this, and we'll continue to hear with the next speakers. And it's something that this is what TB Reach really encourages, to test out new ideas and approaches depending on the region or country involved. So just again, for an example, in Kyrgyzstan, we have a new Wave 8 grant where PPM work it's really not been done. So the approach is a much more traditional kind of referral to the NTP model, where other groups are taking what was described in the JEET model and what the model that Gates supported early with PATH and others in India, and this PPIA or public-private interface models, using private sector drug sales data in now trying to expand that, moving outside India and using in Pakistan, or other very highly successful models like in Bangladesh, using centralized screening centers to provide new diagnostic tools, and both public and private referrals. So there's really a huge variety that TB Reach does support. Teresa and a number of others mentioned the importance of taking the lessons from COVID and moving towards different types of support, remote monitoring, remote consultation and care. And these are things that TB Reach is currently working on with a number of our projects. The remote monitoring devices for improving support for people taking medications, telemedicine solutions, and the idea that TB Reach has is that we really focus quite a bit on M&E. You have a large and amount of support for our M&E system to help the partners document the results so that we can move. And the idea is really to move from the local results of these small projects to policy change. So if you can go to the last slide and that I have on this is really what we're trying to develop more in the current work. We have gotten a lot of very great support from USAID over the last 3 waves, providing funding specifically for private sector engagement. And as I said, Wave 8 was entirely focused on such projects. And in addition to the grant support that USAID is providing, they're also supporting Stop TB to conduct organizational capacity building for all of our grantees, because the idea is that we really try to find local innovators and move from being the local innovators and implementers to larger scale impactful services at a larger scale with other funding. And for an example of how this could work, or how we would like to see this work, and link into what Mohammed was talking about, is just an example from Vietnam, where in 2017 we had a small NGO called FIT working in 2 districts in Ho Chi Minh City. They identified more than 1,000 people with TB that were being treated. They were not notified, but due to policy restrictions, they could only notify a fraction of those people, even though they had identified them. And they applied for scale-up funding for TB Reach in 2019, and that was scaled to 14 districts. And they identified almost 4,000 people with treatment that were being treated, and linked them to the notification system. And just recently now, Vietnam has allocated $5.8 million from Global Fund funding to expand this model to 84 districts. And there was a nice depiction. The next step would then be, as the slide from India showed, to take this and look at national support funding to engage the private sector, and that would be the next step. So we just to close with that, we do want to work with new partners. We really encourage, we hope that we'll be able to have a new call for proposals in the coming time, and to replicate the success in the future, to encourage your new ideas and applications, and we look forward to seeing them. So, and in the meantime, please, yes, just to echo what Monica said about the Global Fund and Mohammed's presentation, really taking advantage of taking advantage of the funding for TB that the COVID-19 support and Global Fund has made available and push all types of work, but especially innovation around private sector. Thank you. Thanks, Monica. Over to you.
Thanks so much, Jacob. Indeed, great to see all the innovations coming out from TB Reach. And yeah, I mean, this is what's pushing the ball forward, along with Global Fund, USAID support, and of course, the Canadian government. Many thanks to you and to Stop TB for this. So now we come to the close of this session. We have a Q&A, but we invite you to continue using the Zoom Q&A function to post your questions. We also would like to ask you to use the Slido to post your suggestions. And given that we're running out of time, we now can move to the next session. Apologies for the delay, but this has been an incredibly useful session. Great presentations from all the speakers, from countries, from partners. Thank you very, very much. So I now turn to Dr. William Wells, who will chair the next session on the PPM COVID-19 assessment and how this has impacted progress. Over to you, William.
Great. Thank you so much, Monica. So we now turn to one of the bright spots, I think, of last year, of the past year, was the PPM Learning Network's efforts to keep this community going and engaged and learning through the PPM Learning Network. Incredible amount of energy put in by Petra, who will speak next, and Joel and their colleagues. So I want to thank them for that in general, and specifically for spearheading this effort that they'll now highlight on the impact of COVID on PPM and particularly on the intermediary agencies. So please, Petra and Joel, go ahead.
Thank you, William, and thanks everyone. I know this is a long slog of a lot of presentations, so maybe as a start, I would just want to say to everyone, reach up your hands, move around for just a second, because there are going to be a few more talks before we're done. We will try to keep it short, but what I'll say, we are going to talk today about the impact of the COVID on the private provider engagement for TB, specifically looking at 2020. What we did a rapid assessment, and we talked to, within the 7 high TB burden countries, we talked to 15 intermediary agencies. So as you've heard in detail this morning or earlier from Guy and from others who have presented, Teresa mentioned also the impact of COVID and how many people are actually suffering, and the data that WHO is showing that there are 1.4 million fewer people actually having received TB care, and that our programs are being set back. In the last 12 months only, it's about a setback of 12 years, and many of the countries have outlined a lot of details in this regard. So moving on to the next slide, I just want to show you, in December, as a team, we talked to people in the 7 countries that you see on the right side, and we interviewed with in-depth conversations the different intermediary agencies around the world, where we talked about the impact of COVID-19 on their PPM programs, as well as their networks of private providers and their own organizations. So we got a lot of feedback similar to what you have already heard from the countries. And we're trying to summarize today some of those constraints, also the responses to mitigate the impact, and some of the opportunities that have actually arisen by the COVID pandemic. So to go to the next slide, you will see here the overview of the different sections that we're presenting. And I'm asking my colleague Joel to start off and present the first 3 sections of this.
Thank you, Petra. So when we looked at the impact of COVID-19 on service delivery, as you've heard from all the country representatives, there was a drop in TB notifications. There was decrease in TB diagnostics. Specifically, we also noted that private practices were shut down, being unable to sustain during this time. And there was a disruption of active case finding and contact tracing efforts through the intermediary agencies. When we asked on what was causing the major impact, it was mainly the travel restrictions and fear of getting COVID infection that completely tumbled the TB care cascade, and it also disrupted the private sector operations and the supply chain. When on certain aspects, there was more focus on COVID, where resources were repurposed for COVID from TB. So this compromised TB care. There were overlapping symptoms of TB and COVID, where so patients were hesitant to admit to having respiratory symptoms, and doctors were also hesitant to diagnose patients with a TB or COVID or any respiratory symptoms. In addition to all of this, there was also a few physicians who or providers who fell ill because of COVID, and that also compromised the TB care. And there was difficulty in adapting to change because life as we knew it completely changed in the past year. So people found it difficult to adapt to this change. The constraints that we saw earlier, it impacted both public and the private sector, but the private sector had added challenges. They were, in some instances, they were either restricted or neglected from seeing patients. So there were some incentives which were focused more for public sector and not for the private sector. And also the small scale providers were impacted more when compared to large scale providers because they were not able to sustain. For the patients, all of this translated as high cost of care. When we looked at what was the major cost, it was mainly to cover the PPE expenses that they had to bear. And also there were other costs. The cost to run a clinic did not change. Cost to run any private activities did not change, but the patient flow was low. So in order to match that, they had to charge more cost of care. When we checked with the intermediary NGOs themselves as to how their work was getting impacted, they had reported a disruption in their outreach activities, all the field work and the medical camps they were not able to do. They had to shuffle their budgets and tasks based on the current need. And also a lot of their staff also fell ill with COVID. And there was a delay in projects. It did not progress as the way they had imagined it for 2020. And the staff also felt overworked because of added responsibilities. Although there were all these disruptions, the private sector rose up to the challenge, and they found ways to adapt to this challenge posed by the pandemic. So one of the main adaptations was the digital transformation, which a lot of you have mentioned even in the Q&A. So the teleconsultation and even for DOTS, there was digital tools that were used for DOTS, and for monitoring and evaluation, there were digital tools that were used. And also for diagnostics, the systems that were already there, they were scaled up during COVID-19. And similarly for notification systems and screening systems like Nikshay had an update during the pandemic. And also the TB Star app by Canos was updated during the pandemic, was scaled up during the pandemic. There was a more focus on patient-centric services, like taking the care to the patient. You heard mitigation plans of how the private providers helped in supporting delivery of drugs to patients' home, and sputum microscopy was done at home. There were also relaxation of DOT guidelines. Patients were prescribed drugs for a longer duration, and they also skipped sputum microscopy and went on to do directly the gene expert so that there is faster results. And there was emphasis on infection and prevention. And there was also integrated screening for TB and COVID simultaneously. For example, the mobile vans partnership between Indus Hospital and IRD, they were screening for TB and COVID together. And there were a lot of bidirectional screening guidelines also that came out. In addition to the intermediary agencies offered additional support to private providers by ensuring they had good supply of PPEs and any other equipments that they need during this time. They also developed guidelines to support the private sector, the private providers during this time, and also they helped by supporting public awareness, by creating public awareness about TB and COVID, as creating advocacy messages around TB and COVID for people to seek care. So over to you.
So thank you. So when we then look at how has this situation actually given us an opportunity to look beyond the COVID pandemic, or actually not so much at that, but how can we reimagine TB care while we're still in the pandemic? All the intermediate agencies were very clear that there's some big lessons that we can learn on how we can improve our programs despite the pandemic and beyond the pandemic. One of the things that came out clearly was the augmentation of digital innovations. And you've seen some concrete examples that Joel brought forward, but also by the countries already. Another point that was brought forward several times was that the focus on infection control and prevention, whether it's in the environmental impact directly in the facilities where people are through ventilation systems, or the larger prevention efforts within awareness raising within communities, is an area that really needs to be taken more control of. We've seen that with the COVID pandemic, how important it is that we engage the larger community. So with that also, one of the key things that was brought forward is the strengthening of diagnostic capacity for TB. If we can test for COVID so many thousands of people on one day, why can't we do that for TB? There's real questions why we don't have better diagnostic tools that are rapidly available. So this is definitely an area where we can strengthen programs. The close collaboration between the government and the private sector has been mentioned by everyone. With the collapse that is happening in so many countries because of COVID, it's even more important that the whole health sector will be repaired, and we can't just focus on the public sector only, as has been emphasized by many of the speakers this morning. Then the last point, or the two last points, the decentralized system and really the focus on bringing services of TB control to the patient's home or the patient's workplace, that has been one key area to keep programs and services going. So those outreach activities are something that needs to become more central as part of TB programs, and primary healthcare services are key in this regard. And lastly, each of the intermediary agencies in our interviews mentions that we need to be more ambitious. If we want to reach the NTB goals, or if we want to get towards the NTB goals, we need to start to become more bold, louder, and we have to really join forces and triple our efforts, as was already mentioned by Madhu this morning as well. So in conclusion, we've seen some tremendous challenges in each of the countries, and yet the private sector and private providers in the different networks of the intermediaries have shown resilience and flexibility and really pulled through. In some instances, we actually saw that the private sector contributions have increased drastically towards the end of 2020 once services resumed. However, as we all know, we're still in the midst of waves of the pandemic, and we don't know how this will fully roll out. Constraints are likely to continue and maybe even worsen in some areas, as we see in Asia now. So some of these identified adaptations are going to be hard to put in place and definitely have not been scaled up. So this is going to be a long-term effort. And we know at the same time that we're not talking about new ideas. We have a PPM roadmap for tuberculosis that was launched in 2018 with many steps, and these steps have even become more important now, recognizing that we can't just focus only on public, but have to engage the private sector in everything we need to do. So in closing, I want to thank all the colleagues that we've talked to that have provided the information, have so much given us input and thoughts in putting all this summarized version together. You will be able to find the more detailed outline with the different points that we have presented in a summary, and I think the link is posted online, and we will share it with you afterwards as well. And with that, I hand back to William. Thank you, William.
Thank you so much to Petra and Joel. yes, I want to really recommend that people take a look at the report. It's got some very clear messages, and we kind of forced Petra and Joel to cram this into 10 minutes, but it's worth taking some time after this session to actually review the report. We're lucky to have 4 of the co-authors of that report to give us the direct country experiences. So I'd like to introduce Tawfiq Ali, who's from IHVN in Nigeria, Sharia Ahmed from ICDDRB in Bangladesh, Ramya Anantha Krishnan from REACH in India, and Amna Rashid from Mercy Corps in Pakistan. So thank you very much for joining us. We'd like to give each of you an opportunity to very briefly respond to 2 questions. So the first question is, reflecting on the presentation that we just had, the report to which all of you contributed, we've heard about the impact of COVID on TB private provider engagement during 2020. But can you give us a bit of an update? Can you give us a picture of the impact of COVID on TB private provider engagement in 2021 as additional waves of COVID arrive and as client and health system behaviors continue to evolve? How have the various challenges and adaptations that Petra and Joel described, how have those changed as we go further into 2021? So I'm going to turn first to Tawfiq, if you can get us started on that question.
Thank you for inviting me to the session. Good morning, good afternoon, good evening, everyone. So for Nigeria, we saw from the NTP manager's presentation, in spite of the COVID restrictions, Nigeria did record increases in case notification. And that largely could be attributed to the new infrastructures that was put in place just before the COVID pandemic. So in 2019, the PPM grant started. Also, the national program became a PR. So we think with this combined interventions, we're able to lay some very good infrastructure that, by the time the COVID hit, we had sort of a safety net, to cushion the effects of the COVID, and we're able to record, that success. But I'll say, in spite of the moderate achievements recorded, both across the public and private sector in Nigeria, we could have still done better because there were lockdowns, there were state restrictions. So, but I think the private sector was able to provide a sort of a cushion where patients who could not go to the public sector, we had that infrastructure that had been laid to provide that sort of opportunity to access care for TB services. But that being said, we've learned lessons during that period. The COVID is still here with us, and so we can still feel the effects. And what we have done is to take lessons learned forward. So the things we put in place during that period that's worked, we're taking them forward and we're adapting. So those are the adaptations we're putting forward to see that we're able to sustain the gain. So what we're doing is, to sustain the investment in digital technology, for instance, where, we're doing notification via digital screening, mobile application screening. We have the MATS app. Also building capacity through e-learning platforms rather than the traditional face-to-face. So we're constantly able to address capacity or knowledge gap in the private sector. We're also looking at providing mentorship, virtually. So we're bringing this on board to ensure that we're changing or we're adapting to the changes and the lessons we have learned from the COVID. Also is community engagement, which is very important. We've also learned that, when we can have patients going into the traditional facilities, the private sector in the community, the chemist shops, the private labs of the community, the PMVs, they are there to offer the services. So we're strengthening our investment, we're strengthening that engagement to see that we're maintaining the healthcare staff or the engagement we have done. For instance, we're accessing the FBO facilities that have not been engaging. we're scaling up to all faith-based facilities in Nigeria that are in the community, and the PMVs, we're also strengthening that to see that those services are readily available, so that if there are restrictions, if there are any reasons why patients can't go to the hospitals, the community care is there. And also we're looking at investing strongly more in having patients increasing their awareness in terms of awareness of TB, in the private sector, knowing that these services are available and they're able to access them. So these are areas we're looking at to ensure that in spite of the modest achievements, we're able to sustain these gains and overcome the restrictions and effects of the restrictions that we experienced during the COVID lockdown.
Thank you so much, Tawfiqat. It's really quite a bright spot in the PPM landscape this year, the efforts in Nigeria. So thank you so much for that. I'd now like to go to Shahrir to give us some reflections on how things have gone in Bangladesh, particularly in 2021.
Thank you, Dr. William. I hope I'm audible. So yes, while we were recovering pretty well at the end of 2020 and at the beginning of 2021, the second wave have hit us quite hard at the March, April this year. So the landscape is ever changing here in Bangladesh. We again have a nationwide lockdown. Well, I would say that we are still learning, but the situation that changed since last year is we have learned to tackle this situation better in our health centers, because our workers in the beginning of excuse me, 2020, they were very terrified. They were under a lot of stress. They didn't, in some places, we had a hard time convincing our workers to keep our centers open, but this is not the case now. Our health workers are motivated enough, and we have been keeping our facilities open throughout the general timings, of course, even throughout the lockdown situation. However, the lockdown has impacted the private sector pretty badly, because as you know, you have visited Dhaka multiple times, and Dhaka is the capital and attracts patients from all over the country. So as we don't have inter-district transportation available right now, many of those patients are not being able to travel to Dhaka. So the overall patient burden in the Dhaka private healthcare system has lowered significantly. I would say it's somewhere around 40 to 50% patient burden has lowered. And this is where we need to intervene, I guess, because we have been in Bangladesh, we have been focusing our PPM efforts on large cities like Dhaka and Chattogram and Sylhet. But I feel that since the people are not getting the means to reach out to those big cities, they are of course reaching out to their local healers, and mainly maybe the informal healthcare providers. So in terms of PPM, this is what we should think of our next step, I guess. We need to somehow find a way to engage the informal healthcare providers throughout the country, rather than focusing on the big cities. Thank you.
Great, thank you so much, Sharia. That's very interesting. I mean, we're basically dealing with a new health system in effect because of COVID. Great, so next I'll turn to Ramya. Ramya is working with REACH with a very wide-ranging project in Chennai. Ramya, how are things looking in 2021?
Thank you, Dr. Wells, and also to the organizers for this opportunity. So I think compared to the first wave, there are several significant differences. A priority given to TB in the private sector has decreased. It was absent last year, but now I would say it's decreased. And if you just like to go along the care cascade of a person with symptoms of TB, I think as mentioned by the previous speakers, the priority now is to get tested for COVID, and so there is a little hesitancy to just go for sputum testing. It's now all the nasal swabs and COVID testing that is taken a lot more priority. Also, in terms of access to diagnosis, as you may know, CT scan and is being widely used in the private sector for COVID diagnosis. So the laboratories are quite stretched, and so access to X-ray screening has decreased significantly. Fortunately, access to gene expert testing still continues, though there are a few issues in certain areas, but in places where there is a lockdown due to transport issues, the access to gene expert has been hindered. One of the very surprising thing that we are seeing is, and this has been, this is something which we are seeing from last year, is the proportion of extrapulmonary TB among all patients diagnosed is almost half. And this probably shows that pulmonary TB people, they are not getting diagnosed or underdiagnosed in the private sector. So if you move on to access to treatment, I think wherever there is this PPIA, PPSA, and there is access to the program and the government supplied drugs, the drugs are being ensured to private sector patients smoothly. Where patients are on private prescription, they are facing a lot of challenges because one is because of the economic activity reduction, they are not able to purchase medicine, and they're also not able to reach out to their private practitioner to find out whether they need to continue their medication or stop the medication, and that's been a huge challenge. Again, another challenge has been the TB COVID bidirectional screening, which is quite strong in the public sector, but is almost negligible in the private sector. Again, we've been also testing people with comorbidities, and another alarming factor that we are seeing is especially people with TB who have comorbidities like diabetes are on poor glycemic control. So we are quite worried about what impact it is going to have on their treatment outcome. In terms of the private sector itself, of course, there's been a significant change in the way they practice. Most of them have resorted to teleconsultations and telemedicine. And we have nearly 1/3 of the clinics closed, either because the doctors are posted in COVID centers or they are undertaking a COVID duty. So this would definitely have an impact on the notification. In fact, in our cohort of private practitioners, about 10% of our high referring private practitioners have died due to COVID and other reasons, and this has also impacted notification in a significant manner. So I think in all, there's been many challenges, but of course, the private sector seems to be able to sort of adapt to these changes. We are getting referrals, we are getting patients put on treatment, but of course, today the focus is primarily on COVID. Thank you.
Thank you, Ramya. I think this is a great reminder that I think the PPM community tends to be sometimes a little bit closer to the patient experience and patient realities. And Joel and Petra highlighted patient-centric services as a key theme in the report. And I think what you just mentioned is also a good reminder. COVID has raised a number of additional barriers for patients, and I think intermediary agencies really see that and have an important role to spread that message to the TB community generally. Lastly, I want to go to Amna Rashid from Mercy Corps in Pakistan. Amna, any updates from you on the 2021 situation in Pakistan? Thanks.
Yeah, thank you very much, William, and thank you for inviting me. It's a pleasure to be part of this very important event. So yes, like many other countries, COVID has definitely significantly impacted the TB care services in Pakistan, and not only in private sector, but definitely in public sector as well. Talking about last year when we experienced the first wave in the end of February and the beginning of March, we experienced an overall decline of 50% in TB case notification in the country. And 50% of the private providers who were engaged with the PPM program, they closed down their services. And we did a rapid assessment quickly to see why these services were shut down and how we can support these providers to reopen their facilities, because our priority was to make sure that TB services can be continued. And if you compare last year with the current year, I would say that the situation was totally different last year because there was a lot of fear of COVID. There were restricted movements. The people have limited or no knowledge at all. Even the private providers, they were not even sure how to respond to this situation. So that's why the situation was really bad during the last year when we had this COVID situation. Currently, if you look at the private providers, they are continuing with providing these services. And as Guy also mentioned in his presentation, that in Pakistan, we have seen enhanced engagement of the private sector during this COVID situation. We have learned lots of lessons during last 1 year. We have made several adaptations to our programs, revised SOPs of many of our activities which required large gatherings. We provided distributed PPEs among the private providers as well as among our field staff to make sure that we are not only able to continue the services, but also ensuring the safety and security of the private providers, the patients, and the field teams as well. We were able to deliver medicines at the doorsteps of the TB patients, and 98% of our registered TB patients, they were able to continue their treatment services without any interruption. We also made sure that by revising the SOPs of many of our activities, we made sure that we can avoid large gatherings. So for example, instead of having our chest camps in the outreach, which involves OPD of like more than 100 people visiting those camps, we converted them into mini chest camps where we engaged area notables for referring the community members to those chest camps, and then having limited number of people at one point in time, introducing triage at the private clinics and the large private hospitals which were engaged with us. We also piloted a component of interactive voice calls. So instead of having gatherings for awareness raising, we were able to disseminate messages through voice calls. And that really helped us not only in improving or in increasing awareness among people, but also in improving self-referrals, in improving, in identifying the hotspots through this intervention. We also introduced a specimen transportation mechanism, which helped transporting the samples from one facility to the diagnostic facility, which actually limited the number of visits of people visiting for diagnosis. So there are a number of lessons learned. Some needs to be scaled up in current year. Some need some modifications as we move on and as we learn more about it. And we'll talk about next actions if there is opportunity. Thank you very much.
Great, thank you, Amna. Yeah, definitely some very nice highlights of innovations there. I think we all know that health systems have changed a lot, and there's been a lot of change in how healthcare is delivered, and a lot of innovations coming through in that work. So I want to turn very briefly to the second question, and I'm going to ask for, if possible, 60-second responses. So if each of you can give a very brief 1-minute response to the following question, which is, taking into account the context that you've just described, the kind of history through 2020 and into 2021, what do you see as the short-term and medium-term actions your country needs to take to improve TB private provider engagement? So really, what are the sort of number one priorities? And again, we'll turn first to Taufiqat, please.
Yes, I'll say in the immediate medium term for us, we need to look at, of course, it's been demonstrated that the private sector is the way to go, looking at our data, looking at our results. So we need to see that we're providing a sort of social safety net for patients who visit the private sector to access TB services in particular. So where we're having health insurance made available, at the state level, at the national level, so that patients, level of out-of-pocket spending is reduced and able to be covered under some insurance. That would really help in improving, the outlook in the private sector, where as patients move there, they're also covered under the insurance network. And of course, we also need to sort of improve funding generally, domestic funding, I would say, as well as seeing that there are more partners coming on board, to work in the private sector. As it is now, we don't have the entire states cover for the entire TB cascade service in Nigeria. Global Fund supporting 21 states, USAID is supporting the other states, but we need more, investment also in the private sector from, other partners as well. So I think those are the key areas where we need to look at, for us to move forward in TB services in PPM. Thank you.
Fantastic. Thank you so much. I think more is always the operative word in PPM. Sharia, your response. Sharia, you're muted. Yeah.
Thank you, Dr. Williams. So for 60 seconds is really tough. As you said, more. Yes, we need expansion of access to diagnostics. I think Bangladesh is doing great in terms of expanding the expert network. We already have more than 200 machines, and very soon we are going to have more than 400 machines across the country. So now we need to increase utilization, and one of the ways of that would be to engage more and more private, preferably the informal healthcare providers, into the mix across the country. And if we want to engage more private healthcare providers, one of the ways would be to engage with the professional associations like Bangladesh Lung Foundation or the Bangladesh Pediatric Association, because these days, the intermediary agencies, we cannot reach out to the providers individually. We cannot sit with them. We cannot have orientation sessions. So it's important that we get in touch with them through online media such as webinars. And one of the ways of ensuring engagement in those webinars would be if we can engage the leadership of those professional associations. So yes, we are doing a great deal in terms of expansion of diagnostics. We just now need to ensure utilization of those diagnostics and bring every formal and informal healthcare provider on board. Thank you.
Great, thank you so much. Next, we turn back to Ramya.
Thanks, Dr. Wells. I think the country has to leverage the experience of engaging the private sector for COVID. I mean, today we have diagnostic, vaccines, medicines, reporting, everything happening in the private sector. And I think it's a huge lesson, and we need to keep these networks alive, and so that we could just layer TB on these existing mechanisms of engagement with the private sector. It's also important to fast track engaging PPSAs, because we need agencies like PPSA to keep the focus on TB alive in the private sector, and to also play a facilitatory and coordinating role for the person with TB who comes to the private sector. Third is strengthening of TB COVID bidirectional screening also is a very critical factor in the private sector. Again, lessons learned from contact screening, especially household contact screening, infection control, use of masks, I think needs to be leveraged and adapted for TB in the best way possible. And I think overall, this whole digital connect has really opened ways of not only reaching out to people with TB, symptomatics, teleconsultations, but also to train, counsel the huge health force who are available within the system. So in all, I think we really need to fast track the PPSA schemes and agencies, again, to keep the focus on TB alive during this COVID times. Thank you.
Great, thank you, Ramya. And finally, we turn to Amna for future directions for Pakistan.
Yeah. Thank you very much, William. I think I would start with the most important point, which is the expansion of PPM across the country. I think engagement of more private providers will definitely is definitely one of the most important steps. And with the new Global Fund grant starting from July in Pakistan, we are really hoping to have a huge scale up in the private sector. I would say the distribution of or availability of PPEs is extremely important to continue the services. Use of online platforms like telemedicine, digital treatment adherence tools, online tools for monitoring, follow up with the patients. These are also very, very important. Capacity building of private providers is extremely important, and this was one of the findings from our health facility assessment, to prepare them for these emergencies and to help them in implementing infection control measures. And also community engagement definitely is extremely important for this. So I'll just stop here because I'm sure my 60 seconds is over. Thank you.
Thank you. So thank you so much to all the four presenters. This was a difficult challenge to summarize such a huge area of work and all of the work that you've been doing in such a short period. But I think we got some really nice feedback in terms of attacking this from all directions. We heard points about patient support, more funding, new ways of engaging with providers through associations, layering TB onto COVID systems, the digital platforms, PPE, capacity building. So there, as I said in my beginning comments, there's a lot of different approaches. We need to come from this from all directions. And that's why all of these innovations from the intermediaries are so critical. So thank you again to all the participants in this session, and I will hand back to Monica.
Thanks so much, William, and thanks to all the presenters and speakers in the session. Really quite very important assessment. We are way over time, but we just have a few minutes for two things. I think one is that we would like to formally launch this assessment with all of you. And for that, I just quickly turn over to Anna, who will explain what is to be done. We can do this offline as well, but Anna will explain what we would like you to do. Anna, go for it.
Hello, everyone. I just share my screen where you can see, to make it short and not waste your time, I'll just skip all of it and go straight to this slide where you can see me and Monica holding our phones with cover of the new assessment. I just posted the link for you to download the cover itself. You can see it in the chat. So what we're asking you to do, please put the cover on your phone as we do it, or just put it on your screen and take selfie and set it either to chat or just do it right now, and I will make the picture of all of you. Just let me know if you can see the link in the chat.
So it's just been posted.
It's just been posted. I just posted once again, so it's a cover of the assessment that Petra been talking about. Can you see?
Mm-hmm. So in the interest of time, if you can, like we did before, take a picture, take a selfie of yourself with it, either yourself or on your laptop, take a selfie and send it to us, and we will use this to promote the launch of this very important assessment. You can also upload it back on the same image site and post the link here like you did for the virtual snapshot, and Anna will compile. So thanks for that, Anna. And this assessment is now available online. We invite you to promote and share as much as possible. Many thanks to the TB PPM Learning Network, to Petra and Joel for leading this work, to all the intermediary agencies which contributed to it, to Madhu and other colleagues as well. So now we come to the last session. We said this would be an interactive event. So we just want to make sure to let you know that we have been listening to your views on Slido. I'll now turn the floor over to Dr. Lal, who will lead this event. So Dr. Lal, over to you. Okay. Give us a second while we...
Yeah, thank you, Monica. This is a rapid fire feedback session. So we are already 1 hour behind our schedule, but still we have to do this. And we wanted participants to give recommendations. And we can see, can you project it, Monica, or should I read it out from my phone?
So it's being projected. There you go.
Yeah, so quick wins and solutions to get back on track. So can we see the recommendations also, the top ones?
Can you show the questions, just the questions for now?
Okay, give me a second. I will go back to the question. Okay. So, Monica, can you see my screen now?
No, not this one. Go back to the Q&A. Right.
Okay.
No, the Q&A. Yes, this one. So Lal, if you'd like to go through, and then we can do the quick vote.
I can't read it. Can you make it bigger? Or somebody from there can read it? Yeah, so the first one is digital transformation to be embraced across all steps in the patient pathway. That got 11 likes. And second one is from, the first one was anonymous. The second one is from Michael Macaria. Integration of COVID services into TB services, advocacy on both diseases to address myths and misconceptions, and which got 10 likes. And third one is anonymous again. Join forces with COVID activities, which got 9 likes. And the fourth one is again anonymous. Bidirectional screening, TB and COVID, which got 7 likes. These are the top ones, right, Monica?
Yes, these are the top ones. What E and Anna have done is they've curated it into a poll. So they'll open it now. Yeah. And yeah, so if everyone can join to vote. So, so if you have signed in to Slido, you can see the top 8 that were recommended. So if you can give your rating, good. As you can see, it looks good. Okay, so please vote for your top 5. And once you've done, click send.
Monica, it was so easy. It worked so well.
Yeah, indeed. Is it possible to show the results about which got what's happening?
Yes, Monica, we can show the results one by one. This is the first question we got, and here is the rate. Would you like me to go to the next one?
No, can you explain it? What does it mean? 56%?
So that is the 5 stars. So 53% said get 5 stars. 55% get 5 stars for this. Is there one final one, E, with who got the most?
We rated by different individual questions. For example, this one we got 50% rate.
5 stars.
Yes, and then if we go to the next one, the result will be here. Okay, let me.
Why is it not sure?
Okay, so here is the third one.
This is the second one?
Yes, let me go back to the second one. Sorry, there is some technical issue with this.
Okay.
Okay,
if you can read it somewhere else, you can say what it is. Yeah.
Here is the second one. We got 60% for 5-star rating. And here is the third one. And the fourth one, the create platform for cross-learning among implementers. And the fifth one, we got 43. And here's the sixth. And go next one. And here is the last one.
So the second one.
The second one, yeah, it was showed. Let me go
that
back.
Gets maximum, no? That gets.
Here is the second one.
Yeah, the second one is the most.
Yeah.
So how do we want to proceed, Monica? We'll have
so thanks so much to everyone for the voting. I think what we'll do is we'll pull which are the top 5, and it's very clear that it's if you look at the question, I mean, what has been posted, you can see that the top 5 are the integration of COVID and TB, followed by, I think it was the platform for cross-learning, which actually we have with the TB Learning Network, which is actually quite good. So we're on the right track. Then there's digital transformation. I think systematic screening also got a good ranking, and as well, yeah, systematic screening did get a good ranking. and improving government capacity. This was the other one. So actually the government capacity to involve private sector ranks second. What ranks first is integration of COVID services into TP. So Lal, we'll pull together, we'll make a summary of this to share. Over to you.
Thank you, Monica. And so anything else in this session? We are done, right?
Yes. No, this was excellent. I think we got some good suggestions.
And the technology also worked very well.
Indeed, we do try to improve, and there are hiccups, but I think with every use, it'll improve more and more.
Yeah. So thank you everyone for participating. And we still have 60 plus people, right? Oh, 70 people.
Yes, 70, yeah. So indeed, so thanks so much, Lal, for coordinating that session. Indeed, it was very rapid fire, unfortunately. So we will compile all of your inputs. Thank you for your interactions. Madhu is Madhu unfortunately has had to leave for another appointment. So on behalf of the PPM Working Group, WHO, the chair, the vice chairs, all our partners, and many thanks to all of you. First to our distinguished speakers from countries, from partners, TBE Global Fund, USAID. I can go on listing all the various intermediary agencies and to the civil society who have participated, the PPM Learning Network, Petrojol, and thank you for joining us at this meeting. We've gone over time, but I think it's been a very rich discussion. We tried to put a very ambitious agenda into a very short amount of time. Thank you for staying on. We have recorded this session. It will be posted on the WHO website as well as on the Learning Network platform and on the PPM Working Group site. So thank you very much for joining, and we look forward to continuing our close collaboration with you. Please do join the various upcoming webinars and the working group and the network so that we can continue this collaboration and a much needed advocacy to end both TB